It's going to be a little bit more technical talk. And if you think of optical imaging, because essentially we are in the field of optical imaging is a method that you guys use all the time, but from a radiologic or nuclear medicine standpoint is the new modality in the sense that although we are very used to use our eyes even to diagnose disease or do procedures, at the end of the day, when it goes to either deeper or more specific imaging, for example, molecular-based imaging, then optical imaging is only emerging these days. Now, of course, this is not absolutely true. Even in 1929, this guy Cutler was transilluminating, for example, the human breast in order to be able to identify disease. And I like to show this image because it shows the two problems of optical imaging. First, even if you see some contrast, you do not know if this is benign or malignant disease. So specificity is not always there. And the second thing you see here is that there's a lot of diffusion, so a lot of scattering. It's the same problem that when you illuminate a laser pointer through your finger, you do not see the bone because of the scatter. Now, when you're a surgeon or an endoscopist, you're only used to look at surfaces, and you get the feeling that optical is a high-resolution method. But in fact, the minute that you go even a few tenths or a few microns inside tissue, then optical becomes a low-resolution method. And I think we had a discussion yesterday already on how we could also go deeper than microscopy with optical in order to be able to detect better disease. So the two problems for specificity from one hand, and the other problem is scattering. And I will discuss first the specificity. So what has been happening over the past decade or so is that there's a lot of development in targeted fluorochromes. Fluorochromes that they can bring specificity to tissue biomarkers and disease biomarkers. So for example, you can have fluorochromes that they attach to specific receptors in cells, trying to target cancer cells, or they can have the preferential accumulation into cells, and maybe nanomedicine here, nanoparticles become relevant. And in fluorescence, there's also this concept where you have dark molecules, but when they see a molecular target, for example, an enzyme, the enzyme will digest the molecule, and then the molecule will fluoresce. And you have an optical switch when there is an enzyme, for example, again associated with cancer or inflammation and so on. And I will focus more on this today, but we're pretty much doing all of these three concepts in the lab. And of course, we're going with biomarkers that they have been already identified as being important for cancer development. For example, in colon cancer, you know that EGFR and 6CR4 and EPCAM and so on, these are biomarkers with high prevalence in the expression in colon cancer. And you can select breast cancer and you can have a similar list. There are criteria on how you can classify these agents for imaging purposes, so which one is the most important and so on. And then the second thing we're doing is we say, all right, so even if we know the biomarkers, how do we actually go about imaging them? So there are many different ways. You can have new chemistries, you can start developing new even concepts, but because we also want to go clinical, and we're doing the new chemistry, or at least we're working with chemists, but we're doing also a little bit of a simpler thing. We're going after drugs that they are targeting these biomarkers. The drugs are already administered into humans, and you know well they're by distribution profiles, and we try to attach a fluorochrome to them and use the drugs also as imaging agents for seeing a disease better. So obviously the concept, and this is in collaboration with the University Medical Center in Groningen, the concept is that you would have, for example, receptors on the cellular membrane of a cancer cell, and this is what you would like to be able to target better, and not just see cancer, for example, on anatomical features like what's happening now, or non-specific dyes, but instead inject, for example, antibodies or other small molecules that they will carry a fluorochrome and they will identify those cellular receptors. So you inject them systemically and they will circulate, they will attach to cells, and maybe they will get endocytosed. But on the other hand, whatever is not doing this, it will clear somehow from the bloodstream so you can get some good imaging contrast. Now, there are many things you can do with these things. And obviously, I know of interest to this audience is probably endoscopy. So instead of going and seeing anatomical features or more developed disease already, because even the flat adenomas are already developed disease, maybe even see earlier markers and identify them based on the fluorescence. So you can start seeing very small microfoci of disease rather than the bigger polyps, let's say. But of course, you can do other things. You can see inflammation in arthritis. You can start doing breast cancer detection, even non-invasively. But I will focus on those techniques today. And our first approach to the matter was trying to improve surgery, realizing that the human eye is limited. The human eye cannot penetrate beyond the surface. It is not specific to cancer in particular. It is also only specific to alterations, anatomical alterations, maybe color alterations. So you saw here the surgeon injecting a red agent that would be maybe specific to cancer cells, and also injecting a green agent, for example, to identify the lymphatic system. And then move a camera into the field of view and go and find, in this case, for example, the sentinel lymph node with the green dye. But we are more interested even in going after the primary tumor and inspecting to see if there is positive margins left behind after you resect the primary tumor. So this is the first thing that we want to do. Inspect, not so much, of course, for removing the primary tumor, but look for local regional metastasis or margins that they are left behind. Now, using dyes even in surgery is not a new concept. Even in the 40s and 50s, people were using these fluorescent dyes for, in this case, identifying borders around gliomas. But the problem with these fluorescent dyes is that they're not specific. So they're just distributed in the vascular system and then they somehow cleared, but they are not targeting cancer cells. So they never worked that well. So we knew that we actually have to devise those targeted agents, but also clinically translated, so go through the regulatory barriers. And then, of course, we knew that we had to develop accurate fluorescence signature systems, that they are sensitive and accurate in order to be able to do this detection. And I'm not going to go into the technical details here, but what we're doing is we have real-time multispectral imaging. What this means in a little bit more practical terms, we're having not one camera, but we have a system with multiple cameras. So one camera can visualize color, the other camera can visualize with very high sensitivity fluorescence. We have a third camera to be able to take signals that we need to do corrections on the fluorescence to make this more accurate. But I'll just show you how this looks like. So we can have a color video, and then in real time in the computer combine the fluorescence video after we injected, this is a tumor here, and we injected the fluorochrome. This is a mouse, and it targets the tumor, and you see this green fluorescence. Now, this is not green fluorescence. This is just fluorescence detected from a highly sensitive camera. We paint it in the computer green and superimpose it on the color video, so if you're a surgeon, you know where the fluorescence is while you're seeing the video, the color video. So this is synthetic video done in real time. And I can show you some examples of the concept. So we're working together with surgeons. In this particular case, we had a tumor here implanted in a mouse. We used an agent that targets integrin AV beta 3. And here you have the fluorescent signal from the tumor. Here's the tumor anatomically. And the tumor cells were also expressing bioluminescence, so they were naturally also emitting light. So this is the tumor at 100%. And then we told the surgeon, just take 90% out and leave 10% just to show that we can still see the tumor. And here is the tumor after 10%. And then after completely removal of the fluorescent signals, we could show with histology that there was no tumor left. Great. Now this is another example. This is another tumor. And we told the surgeon, based on the color image, take 90% out of the tumor. So he did that and he left 10%. But he also left a spot here that it was not intentional. It was just a fluorescent spot. He thought that he removed everything here, the spot is here. So we were very interested in this particular spot, and there were some other spots too. And so histologically analyzing this, we found that there was cancer cells. And again, this is the idea of fluorescence. It's not based on resolution necessarily, but it's based on specificity. So even if the resolution here is not microscopic resolution, you still get a signal that could be indicative of cancer. And maybe you can even go with a confocal microscope and do an in vivo high resolution imaging. But the most important thing is to have these pointers on the fluorescent signals to know that that may be something more there. So we took this camera into the operating room. Here you see the camera. Essentially, the camera is this 3-head camera. It has a common lens here, and I'll show you also implementations for endoscopy. There's a patient here prepared. This is for breast cancer surgery. Now, we plug the camera directly into the screens, into the monitors that are already there in the OR, but we also have our own monitors. And the system is just based on a surgical arm used for a surgical microscope, and it's just rolled on top of the patient. And we started doing this clinical translation. So we essentially got approvals to inject an agent that targets the folate receptor alpha. And since this receptor is overexpressed in 95% of ovarian cancers, we applied that to ovarian cancer surgery first. So this is now the open surgery. This is the abdomen. And now if you switch to the fluorescence, you can actually see the fluorescent spots here. So this is obviously what you see with your eyes. But here you have this signal. This fluorescence now is a molecular signal. It tells you where folate receptor alpha gets overexpressed. And you can see you can do this. This is just a visualization. This is the fluorescence image. This is the color image. But of course, we can put those together. So I'm just going to show you another case. This is, again, another patient from the same group of patients. Again, a folate cancer positive, an ovarian cancer positive patient. And there's a nodule here. Experienced surgeons, they will start seeing a lot of nodules. But the question is, how many nodules can you see? And this is not the question how good of a surgeon you are. It's a question, how good is the human eye in detecting under the surface and detecting very small cells? It has nothing to do with the experience. It has to do with the capacity of the detector that you're using during surgery, which is the eye. So this is how the same view looks under the combined surgery, under the combined imaging with fluorescence. That was a very distributed disease, not a very good case. But you start seeing very small spots. You're seeing things that maybe would have missed with the human eye. And in this particular case, and this is just a pilot study, don't ask me to tell you exactly what is the clinical use and outcome of this. It is the first time that this is happening, so it is more of a demonstration. But we asked surgeons to validate how much tumor they could see with just vision versus the fluorescent signal. That was done in high-quality photographs, of course, because we didn't have 6 surgeons in the OR. So 6 surgeons got photographs and then got this type of images. And they could identify, you can find in this publication, 5 times more tumor based on the fluorescent signal in this particular case, which is, of course, a difficult case, but it just shows the potential. And here you see just an overlap because the surgeon moved his hand in. So essentially what we're doing, again, just as a summary, we're taking a color image, we're taking a fluorescence image. This is a grayscale, high sensitive fluorescence image, and then we combine them in a computer in real time so that you can get the synthetic video. So you don't also have to switch between color and fluorescence. You do this simultaneously. And of course, we can use these cyanin dyes to identify the lymphatic system as well. And this is just a sentinel lymph node. This is the site of injection directly into the tumor. This is breast cancer now. And we can see the sentinel lymph node, the lymphatic system. And our hope is that we can use dyes to also see cancer in the lymph node so that we know before even resecting the lymph node if it is positive or negative. So we have a clinical translation program we're trying to build up. I mean, maybe this looks a little bit enthusiastic here, but pretty much we have all of these agents. And I can just briefly tell you we have agents against cathepsins, against vascularization, matrix metalloproteinases, integrins, VEGF, EGFR here too, pretty much receptors or enzymes that are associated with cancer growth and they're associated with the propagating front so that we are able to identify better tumor margins. And we are hopefully in next week, we will start the second clinical trial using this bevacizumab labeled with CW800, which is a fluorescent dye. Essentially, this is Avastin, labeled Avastin that we're using to detect breast cancer. So, as I said, this could apply also not just to surgery, but potentially endoscopy, colonoscopy, and other endoscopies. And we like the systemic injection versus spraying, although I would be happy to discuss this, because especially in colonoscopy you have a large organ and it's better just to do a quick pass and know if there is any molecular abnormality based on the fluorescent signal. And the problems with advanced techniques have been already identified, both the advanced techniques and the problems with them, with narrow band imaging, autofluorescence that is not particularly specific maybe. Of course you have the confocal laser endomicroscopy. And this is a great technique. You can see a lot of detail. Of course, this is an adenocarcinoma. This is with a pentax scope. But the problem again here is where do you shoot, where do you point the scope if you want to do this? And if you had a fluorescent signal showing suspicious lesions, then you can actually take more advantage of techniques like this. However, what we're promoting, and that was published last year in Gastroenterology, is this setup, where we have a clinical near-infrared endoscope to visualize essentially in the fluorescence mode of more superficial lesions, and we have this optoacoustic endoscope to visualize lesions that they are even deeper in the colon than what is allowed by microscopy today. And I don't know how many of you have heard of optoacoustics, but I will just describe it briefly. I know I'm not having much more time. But it's a powerful technique, and I would like to just tell you a few slides about it. Now, for the fluorescence part, so for this part, our camera has, it looks like this because it has some very nice optics. So pretty much it can adapt to anything. It can adapt to a lens to do open cancer surgery. It can adapt to a laparoscope to do laparoscopy with this. And it can adapt to a flexible endoscope to be able to do endoscopy with that. And these days we're collecting with everything. So we have done also laparoscopy and endoscopy with humans. It's just early. We just have a few patients. Hopefully by the end of the year we'll have more results also from the endoscopic procedures. However, the second problem, it becomes a little bit more technical, and I know you're becoming a little bit more tired, but just bear with me for a few slides here, is this problem of scatter. So we solve the specificity with the targeted agents, but what do we do with depth? Because everybody knows microscopy does not penetrate deep in tissue. It only goes for a few hundred microns maximum. And the problem is that as light, like a laser pointer like this, is shot into tissue, just after 100 microns, it already becomes diffuse. That's why in classical microscopy, you have to cut a slice of 10 microns to avoid all of the scatter. And there's advanced techniques like confocal that goes maybe here, 2-photon that goes here, but you start getting diffusion and you're losing signal. So even the most advanced forms of microscopy, they could go down to maybe 0.5 millimeter in tissue. So what if you want to see beyond the 0.5 millimeter? What do? And here comes this method that we're developing. It's called multispectral optoacoustic tomography, and it can revolutionize the way optical imaging is done. Because what it does is it shoots light into the tissue. It's nanosecond pulses. It's very fast pulses. The light will propagate into the tissue and gets absorbed by absorbers, like fluorochromes, like hemoglobin, like melanin. And here something very interesting happens. When an absorber absorbs a light pulse, it gets temporarily heated up, and heating increases its volume. And because the volume increases, but also decreases quickly, it generates an acoustic wave. And so we can capture this acoustic wave with an acoustic sensor. So we shine light, it's light in, but sound out. Essentially, we listen to the light being absorbed. And it sounds pretty sort of a little bit out of reality, but this is a very practical technique. It's been done since the 70s. And the issue here is that because we're using sound now, we do not care about photon scattering anymore. We can detect, we can have optical imaging without caring about the photon scattering, which is the major problem. You see a 3D of this. The light pulse comes in, warms up to absorbers, and it generates an acoustic wave, and you detect it with a detector. Now, you may be asking yourself, how did we go from fluorescence to this crazy physics stuff, and how is this useful? I'll skip that in the interest of time. The first thing that we can see when we can see absorbers with high resolution in tissue is blood vessels, because hemoglobin is the major absorber. So we can go through an entire tumor here, 7 millimeters, and see maybe with 30 microns blood vessels in the tumor. Of course, in the mouse here, but also through 7 millimeters, we can start having high-resolution optical imaging. This performance has never been present before because microscopy will only penetrate down to this depth. So we can do three-dimensional slices and we can see the vascular system of the entire tumor. What else can we do? We can see things in real time. This is the injection of a fluorochrome now because a fluorochrome is an absorber into a tumor. So the tumor is here in the back of the animal, and this is now a cross-sectional image through the entire mouse, but this is a high-resolution optical image. This is not ultrasound, this is not MRI, it's not CT, it's a high-resolution optical image through an entire mouse. Again, microscopy would go down to this depth, only to this depth, and here we have 1.5 centimeter. This is about 150 microns, and it's in real time, so you can see a fluorochrome, we inject it here in the tail vein, coming and perfusing in a tumor in real time. And I apologize for one more technical slide, but essentially, if you want to see fluorochromes with this, now you can throw different wavelengths to them and do this technique called spectral unmixing, so essentially you can capture the fluorochrome based on its absorption signature. So we can see fluorochromes with this technique. So what we have with this multispectral optoacoustic tomography, it's an optical imaging modality that penetrates much deeper than microscopy and can see with high resolution fluorochromes, melanin, blood, hemodynamics, things like this. So I will go just to show you this slide and what it means. Again, we have a tumor. We can have an anatomical image based on optical absorption. We can have a molecular image by resolving a targeted fluorochrome and where it goes. And we can have also an image of hypoxia versus oxygenation. We can see an artery and a vein. This is about 1 centimeter of tissue here, because oxygenated and deoxygenated hemoglobin have distinct spectra, and we can also resolve them simultaneously with resolving a fluorochrome as well. And this just shows, it was published a couple of years ago, that we can do very high resolution imaging, so we can go down to 30 microns, 20 microns, and so on with this technique. So I think by combining optoacoustics and combining fluorescence, we're solving the fundamental problems of optical imaging and the fundamental problems of the eyes, because we're imparting specificity, sensitivity, but also the ability to visualize beyond the surface. And we're already developing this in collaboration with my former institution at Harvard and MGH. We are also developing now rotating system to image hollow organs, so not just doing front imaging endoscopy like with laparoscopy, for example, but also being able to go through hollow organs like the colon or like blood vessels, and by pulling down a rotating system that does both fluorescence and optoacoustic, generate three-dimensional images that they go, it's three-dimensional. It's like the ultrasound that the previous speaker showed, but with optical contrast, essentially. So with that, I would like to end my talk and say that we're having the tools both to get the specificity, but also to go beyond the traditional penetration limits of microscopy for small animals, large animals, and even larger animals, so go to humans, and help surgeons, endoscopists, and probably other physicians as well use optical imaging to diagnose or treat disease or follow-up treatment of disease better. There's a lot of people to thank in my institute. A lot of the optoacoustic developments are done with Daniel Razansky and Amir Rosenthal and Nikos Deliolanis, and a lot of the fluorescence are led by Jürgen Glatz here and Max Koch, I don't know where he is. And there's a lot of funding to our knowledge, and these are my major collaborators on the data I showed you. Thank you very much for your attention.